summary of this whole acute stroke paradigm, the first question you have to ask is, when is the last known normal? Next question is, what is the stroke scale? There is a NIH stroke scale, National Institute of Health stroke scale. It's kind of like an abbreviated exam. And the third thing is the blood pressure less than 185? Okay. Once you are done, you do head CT, make sure there is no bleed, and then if all the contraindications, there are no contraindications, push TPA. So the percentage that TPA dissolves, for example, if there is a MCA occlusion, TPA dissolves only 20% of the clot. 80% of the population, TPA doesn't dissolve. If some people have right carotid occlusion, only 10% of population, TPA dissolves the clot, right carotid. 90% of the population, TPA doesn't dissolve the clot. It dissolves peripheral clots, right, at a capillary level, not like big clots sitting in aorta and internal carotid artery. So that's why always think about the clot sitting. So immediately, usually in emergency rooms, we are doing CT, CTA in one push. So time is brain, right? Every minute there are 2 million brain cells are dying, 2 million. And trillion synapses are dying, trillion. So if somebody is having acute stroke, time is brain, and the number one morbidity in this country is because of the stroke. If somebody gets heart attack, they will die, done. But with stroke, people have hemiplegia, locked-in syndrome, aphasia, they are bedbound, pee, poop in the bed. It's such a catastrophe. So to prevent that, the medicine, that way we treat, changed in last 2 years. So there are 4 randomized controlled trials came in 2015. Mr. Clean, Netherlands, Escape, Canada, Extend IA, Australia, and Swift Prime, America. All these trials showed that it is such a powerful treatment. You were in family medicine before, you see people giving aspirins, right? You have to give 200 or even 300 aspirins to prevent one stroke. But if somebody has internal carotid occlusion or a middle cerebral artery occlusion, the number needed to treat is 3. So such a powerful treatment. So if any 666 rule, if somebody's last known normal less than 6 hours, if somebody's aspect score is greater than 6, right, and groin puncture, you are taking the patient into the cath lab less than 6 hours, do the thrombectomy, right, 666. And last year back, we did Dawn trial. Before the stroke, we usually treat until 3 to 4.5 hours for TPA. Recently, 2 years back, we got thrombectomy until 6 hours. But last year, 2 randomized controlled trials published, Dawn and Diffuse 3, which extended stroke window from 6 hours to 24 hours. So what do you think is the number needed to treat in 24-hour stroke window? Random thoughts.
2?
Perfect. How did you guess that?
You said 3 before, so it's going to assume it's go under.
So 2 to 3, because in these extended windows, we used MRI brain. Rather than asking last known normal, because, you know, a young person, their brain works differently, 80-year-old brain works differently, who is cocaine addict, brain works differently, right? So we are looking the tissue pathology rather than blindly going with last known normal. So we did tissue diffusion perfusion mismatch. and there is a diffusion perfusion mismatch, then based on that we take those patients to the thrombectomy. So number needed to treat is 2.5 in that ballpark. So that is the whole stroke paradigm. So time is brain. So time is tissue also. So tissue is brain. So don't waste time.